medicine here, and prior to coming here was assistant professor of medicine and oncology at Ohio State. She does both clinical work and translational research. Translational work is focusing on radiosensors for rectal carcinoma and analyzing colorectal cancers that carry microsatellite unstable characteristics. So some very complex studies that she's doing, and we appreciate and look with interest hearing from you, Christina.
Thank you. So thanks for inviting me. So I was asked to probably spend a few minutes just about, sort of how I got here. And I wanted to also take this opportunity to plug oncology for any of the trainees out there who haven't decided yet. Just to let you know, when I went to medical school and when I was doing my internal medicine residency, I never thought I would be an oncologist. And it really happened because one of my senior residents who had just matched in a HemOnc fellowship said, go try an outpatient rotation. You actually might like it. And I spent this month doing an outpatient rotation with Dr. Horner when I was at UMass. And it was a really, really great experience because we had great relationships with patients. People were surviving, they were tolerating treatment, and they were not sort of the sick population that we usually see in the inpatient. So I really found that really gratifying. And the other part of it has really been the clinical research that I've been able to do during my training and also now has been really, really rewarding. And so anyone who is undecided or interested in oncology, please come and do a rotation with us. So first, I'm going to be talking about colorectal cancers, and I'm going to start first with a case study to illustrate some points I want to emphasize at the end of the talk. So first of all, a 55-year-old male patient who's been actively dieting and exercising. He presents with rectal bleeding, constipation, a weight loss of approximately 20 pounds in the last 3 months, and he's never had a colonoscopy. His father actually had a colon cancer at age 50, and when we do a physical exam, we see mild hepatomegaly. And looking at the laboratory evaluation, we note that there is microcytic anemia. So just for a question of what are the next steps for this patient, do we do a CT enterography? Do we give him some IV iron for iron deficiency anemia? Do we ask for a colonoscopy? Do we do stool coac? And really, this is really to illustrate sort of modalities and all the things that we associate with colorectal cancer and what's appropriate and what are the next steps. So for screening colon cancer, for people who don't have symptoms, we would do a CT enterography or stool coac. So this patient already has rectal bleeding, weight loss, we're already worried. So it really would be a colonoscopy so that we can get a biopsy and confirm the diagnosis. And please, even though patients are young, if they have iron deficiency anemia, please do a workup, not to empirically treat them with iron, because we really have to find out why they're losing blood. So a colonoscopy is done, a rectal mass is visualized, the scope readily passes through the mass, and the biopsy unfortunately confirms moderately differentiated adenocarcinoma. So the question is, what is the next step? Do we call surgery for resection? Do we start chemo? Or do we complete staging with scans? And the answer is to complete staging with scans because we're concerned as to whether this cancer is localized in the rectum or has it spread elsewhere. And so CT scan, unfortunately, now shows that there are multiple liver lesions. So we have now established a diagnosis. We've now staged the patient, and it's metastatic rectal cancer. We do a blood test called serum CEA, which is a tumor marker, and it's elevated at 150. Normal values are usually 5 or lower. That depends on the lab you're at. It's good test to do once we have the diagnosis, but it by no means is a good screening method because patients with a lot of cancer can have normal CEA levels, and so that's not always reliable as a way of diagnosing, but definitely something we would follow as we've diagnosed a patient, and then as we treat them, we want to see that level fall or normalize. So this is the outline of the talk today. First, to briefly talk about the epidemiology of colorectal cancer, and then on to screening guidelines. And then next, on to hereditary syndromes, what the diagnostic workup is. And I'm going to briefly touch on the different type of treatment modalities we have, especially, targeted therapies where we have biomarkers and we now can find different mutations that we want to know and target. Also about molecular subtypes. And finally, sort of a new finding about how right and left-sided colon cancer are actually different. So colorectal cancer, by definition, are adenocarcinomas that occur anywhere along the large bowel, all the way from the ascending, transverse, and descending into the rectum. And this is a surgical specimen where we can see small and large polyps, and also that sort of ulcerating, fungating look of a colon cancer as well. So colon cancer is actually the third most common cancer in both men and women. So it's third after prostate and lung for men, and third after breast and lung for women. The good news is that death from colorectal cancer is actually decreasing. When we look at the death from 2006 to 2010, both in men and women, we can see actually that the incidence of death from colorectal cancer has declined. And this is true for the United States, which is the red line in the bottom figure, as well as the other countries in Europe as well as in Asia. However, more disturbing, though, is a trend of an increased incidence of colorectal cancer in young patients. So if we only focus on the black and the gray line, that's for the patients, people over the age of 50, we can see that from 2010 and sort of projected out to 2030, we're going to have a growing decrease in incidences of colorectal cancer. But what's really disturbing is if you look at the blue and the orange lines, those are for people aged 20 to 34 and age 35 to 49, there's actually going to be an increase. And it's projected that by 2030, 11% of all colon cancers and 23% of all rectal cancers will actually be diagnosed in patients younger than the screening age compared to what we see in 2010. And why that is, we still don't really understand. And some people have thought, could it be related to the sedentary lifestyle that we now have? Could it be related to our dietary factors? So we still don't really understand why that is. But I think the take-home message is that if people are having signs and symptoms that are worrisome, that we shouldn't hesitate, we shouldn't think disregarded just because they're of a young age, but we should definitely do a proper workup for them. So when we talk about risk factors, I like to think of things that are lifestyle related, things that we can change, and other things that we can't change. So lifestyle related, there are associations with diet that are high in red meats, processed meats like deli meats and hot dogs, and high in animal fat and low in fiber. Physical inactivity is another thing that's associated with increased incidences of colorectal cancer, obesity with BMI greater than 30, smoking, alcohol consumption, and diabetes. These are all associated risk factors that we can change. Risk factors that we can't change. Increasing age, a family history of a first-degree relative having colorectal cancer, racial and ethnic backgrounds. We know African Americans have a higher risk than Caucasian. Personal history of polyps, and a personal history of longstanding inflammatory bowel disease also put people at increased risk, as well as inherited syndromes. And protective factors can include NSAIDs like aspirin, exercise, high fiber, low fat diet, and there's some suggestion of folic acid supplementation and vitamin D and calcium as well. So this is a pie chart showing colon cancers arising from various familial risk factors. So you can see the large part of the pie, the blue part, is sporadic cases. So those are not related to any familial syndrome. The red piece, which is a large piece as well, talks about familial risk when people have first-degree relatives and so forth. But it's really the smaller one, the smaller two pieces, Lynch syndrome, also known as hereditary non-polyposis colorectal cancer, which is about 2 to 3% colorectal cancer patients, and then familial adenomatous polyposis, which is about 1% of the patients. So I'm going to go into a little bit more detail about the hereditary syndromes because I think this is an important thing to recognize, even just from taking a history from patients who are diagnosed with colorectal cancer. This actually also may come up in your boards. I think these often pop up. So FAP are patients who have hundreds to thousands of colonic polyps that are seen when they have a colonoscopy. And this actually puts them at high risk of developing mutations in these polyps and then becoming tumors. And this occurs at a very young age. And so this is due to germline mutation in the APC gene, which we know usually is mutated in the progression of even sporadic colorectal cancers that are not hereditary. And FAP is in 1% of all colon cancers, and this is autosomal dominant. And the other thing to recognize is that they can also develop tumors outside of colon, including CNS tumors, small bowel tumors, thyroid cancer, pancreatic, gastric cancer, as well as pediatric hepatoblastoma. And the treatment for someone who's diagnosed with FAP is actually going to be a proctocolectomy or colectomy. even before they develop cancer, to prevent the development of cancer. And after that, it's surveillance with endoscopic evaluation of the remaining bowel, including upper endoscopy and also an annual thyroid exam. So if we do find a patient who has an APC mutation in one family member, then we want to detect it and screen the other family members to see if they have that APC mutation. We'll then have screening guidelines that are very different from patients who don't have that APC mutation. And so this has big implications not only for the patient themselves, but their family members as well. So Lynch syndrome is also known as hereditary non-polyposis colorectal cancer. So they don't have the sheets of polyps that you would see on a colonoscopy. And this is due to a germline mutation in genes involved in DNA mismatch repair. So, and these DNA mismatch repair proteins are important in the surveillance and repair of errors that occur during DNA synthesis by DNA polymerase. And MLH1, MSH2, MSH6, and PMS2 are the 4 different proteins. Now, I'm going to come back to this later on when we talk about therapy, because we've now found this to be an important biomarker for patients who are going to be sensitive to immunotherapy. And the way I think about it is if you were typing, a Word document and your spell check didn't work. So you would have all these errors, these spelling mistakes, and these mutations that can occur, and therefore increase the chances of developing cancer. So that's how I kind of look at how DNA mismatch repair works. So Lynch syndrome is in 2 to 3% of all colon cancers. It's also autosomal dominant, and patients present with colon cancer at a young age. So we historically use the Amsterdam criteria, which is sort of taking a history and this 3-2-1 sort of criteria where three or more family members having colorectal cancer, 2 or more successive family generations, one or more person in the family having colorectal cancer before the age of 50, and we've excluded FAP. But however, we found that this is probably not the best way to be screening for patients with Lynch syndrome, and so really we are now screening all colorectal cancer patients for Lynch syndrome, and these 2 technical methods are how we are doing it. So on the left, it says mismatch repair proteins by IHC, which is immunohistochemistry. So basically, we take the tumor samples that are surgically removed or biopsied, and we stain them to see if there's presence of these proteins in the tumor. So you see MLH1, PMS2, MSH2, and MSH6. And so in this specific example, you can see that the MSH6 tumor has no staining, no brownish dark staining of that tumor. So we would say that this patient has deficient mismatch repair proteins because they're missing one of the proteins. And they're going to be, and then we actually have an algorithm where we then screen them for Lynch syndrome, because you can have missing proteins also sporadically if there's silencing of the gene by hypermethylation, which is not related to germline mutation. So this is one way that we're going to be screening all our patients for Lynch syndrome. And I don't know if you've ever looked at a pathology report here, but our pathologists will do that reflexively. To the right, it's another technique called macrosatellite instability by PCR. And so macrosatellites are repetitive DNA sequences that are throughout the genome. And we recognize that people who have this DNA mismatch repair deficiency will make a lot of mistakes, and these macrosatellites will be shortened and different in sizes. So in this specific example, we have 5 different primers that are listed on the top, and N means normal tissue, and T means tumor tissue. In this case, the patient has macrosatellite stable tumors because you can see that all the peaks in the normal tissue and the tumor tissue line up perfectly. But if this was a macrosatellite unstable tissue, then you would see that those peaks would shift, and the tumor samples would be different from the normal tissue. And macrosatellite unstable high tissue are the equivalent phenotypically. Basically, they represent tumors that have a deficiency in mismatch repair. So Lynch syndrome also has extracolonic tumors. We also think about breast cancer, pancreas cancer, gastric, gynecologic, and GU cancers. And so screening recommendations are colonoscopy starting at a younger age of 20 to 25, an EGD and duodenoscopy at age 30 to 35, as well as a urinalysis to look for cytology for any signs of bladder cancer. And often women are counseled about prophylactic hysterectomy and bilateral salpingo-oophorectomies as well. So the CAP2 study actually looked at patients who are Lynch syndrome carriers. who had not developed colorectal cancer, and they randomized them to these 4 treatment groups. I just want you to concentrate on the aspirin 600 milligrams versus placebo, because ultimately they did find that aspirin intervention, when they followed up these people who had not developed colorectal cancer, that at around 56 months, they found that aspirin intervention did actually improve outcomes, did have lower incidences of colorectal cancer in patients who were Lynch syndrome carriers. And there was even improvement, it was an even better protection if people were on the aspirin regularly for a duration of 2 years. So right now, it's hard for us to recommend aspirin at such a high dose of 600 milligrams because that comes with its own complications. But we do talk to our patients who may be Lynch syndrome carriers about taking a full aspirin and whether they could tolerate that as something to discuss. So the final syndrome to talk about is Puetz-Jegher syndrome, and I think this is one of those where we want to pick them out because there's freckling on the lips that we can detect, and it's due to germline mutation of serine threonine kinase, STK11, also autosomal dominant. And diagnosis is made out of 2 of the following: freckling in the mouth, lips, fingers, and genitals, or more than 2 polyps of the small intestine, and the family history. And again, we have extra colonic tumors that we also have to screen for, like breast, ovarian, testicular, pancreas, small intestine, and stomach. And surveillance is mammograms starting at a younger age of 25, upper endoscopy and colonoscopy in the teens. There's some debate about pancreas imaging, but small bowel imaging, testicular exam, pelvic exam, and pap smears, these are all surveillance recommendations for people who are diagnosed and confirmed with Puetz-Jegher syndrome. So onto screening and early detection. We know that screening and early detection definitely works and helps prevent colorectal cancer. We know that cancers have to evolve from small little adenomatous polyps and then sort of accumulate mutations causing severe dysplasia and finally become invasive adenocarcinoma. So when we think about our screening methods, there's colonoscopy where we examine the whole colon and the rectum. There's sigmoidoscopy, which examines the rectum and lower section of the colon. CT colonography, which I mentioned earlier, which is a CT scan, a virtual colonoscopy. But unfortunately, this really doesn't save people from having to do the whole bowel prep. And if there's some abnormality seen, they still have to then go back and get a colonoscopy because you can't biopsy. And then finally, a fecal blood test. And for staging in colorectal cancer, we do the TNM staging. T is tumor, how far through the bowel wall have we gone. N is nodal status, and we can only really confirm this after a surgical resection. The M, or metastases, we can do that by staging, and that's why I said CT scans or PET scans that we usually do can help us completely stage the tumor. And the difference between a stage 2 and a 3 is the presence of lymph nodes in the stage 3 colon cancer, and and stage 4 is really when they have metastatic disease, when it's left the colorectal area. So this is the distribution of the stages on diagnosis. So 39 and 37%, the yellow and the blue chart, showed localized and regional cancer, meaning probably stage 1, 2, and 3 cancers. And the good news is that it's the majority, but 20% of people present with metastatic colorectal cancer, and we really have to do better, and that can be achieved by people following national guidelines and doing screening practices. And we know that the stage of diagnosis affects survival. So stage 1 disease, we're talking about a 94% survival rate. When we're stage 2, 82%. Stage 3, it's 67%. And finally, stage 4, we're talking about an 11% survival rate. So definitely the earlier we can diagnose it, the better the survival. So surveillance guidelines, we know that the majority of cancers are detected after the age of 50, and that's why we start screening at the age of 50. So if it's colonoscopy, if you have your colonoscopy age 50 and it's clean, no problem, then you repeat in 10 years. So if it's a CT colonography, you'd have to repeat it in 5 years. A flexible sigmoidoscopy every 5 years. We really don't do air contrast barium enemas, but that would be every 5 years. And then finally, we have fecal blood tests, fecal immunochemical tests, and stool DNA tests where you have a little card, you check your stool, and these can be either done annually or every 3 years. But again, these are for screening. So once you actually have gross blood or rectal bleeding, these are not going to be acceptable. Really have to move on to an exam like colonoscopy and so forth. So this is a study back in the New England Journal of 2012 where about 155,000 patients aged 55 to 74 were randomized to either screening with a flexible sigmoidoscopy or usual care. And they found that there was a 21% reduction in the incidence of colorectal cancer, 26% reduction in deaths from colorectal cancer, and 50% reduction in mortality from distal colorectal cancer. So signs and symptoms at presentation, I think most of us know, but right-sided colon cancers may present with iron deficiency anemia, and left-sided colon cancer with obstruction. So patients complaining of change in bowel movements, diarrhea, constipation. There may be frank blood in the stool. People sometimes present with perforation of the bowel. There can be abdominal pain or cramping, weakness, and very vague symptoms such as weakness and fatigue, and also an unintentional weight loss. So the diagnostic workup really is to check blood work, CBC to look for anemia, a CMP to look at how the liver and kidney function's doing, a serum CEA, colonoscopy with biopsy, and finally staging with a CT scan or a PET CT scan. And so on CT scans, we can detect metastases in the liver, metastases in the lung, which are common sites. And to talk about metastatic colorectal cancer, we've actually made a lot of improvement over time. If you look at the 1980s, it was best supportive care versus 5FU, one of our chemo agents that we still use. But sort of over the last 10 years, there have been the addition of numerous chemotherapy agents and targeted agents that I'll go into a little bit. And we've really been able to prolong survival and improve the quality of life of our patients. And right now we have immunotherapy that we can potentially offer patients that have that microsatellite unstable type of cancer, which I'll talk about in a bit. This is a very simplistic view of management, but I think it was worth bringing up. So for non-metastatic patients with colon cancer, they go on and have surgical resection, and then we often talk to them about whether we would offer adjuvant chemotherapy based on the risk of recurrence. For rectal cancer patients, because it's more distal in the pelvic wall and we worry more about local recurrence, we actually do trimodality treatment with chemoradiation, surgery, and chemotherapy if they're stage 2 or 3. So we actually treat colon and rectal cancers very differently in the early stages. But once they're metastatic, then the treatment options sort of merge. And we treat them with chemotherapy, 5FU oxaliplatin, 5FU irinotecan, and really a lot of the beginning of oncology was finding the right chemo for the right patients and try to make it tolerable for our patients. But now we've gone into the era of precision medicine where we can find different targeted therapies that we can add on, as well as immunotherapy. And I'll be talking a little bit more about targeted therapy and sort of biomarkers and how they sort of were discovered. And colorectal cancer is one of the few metastatic cancers where we can still talk about surgery. So if they're isolated lesions in the lung or the liver, we do evaluate to see if they can be surgically removed. We can treat them with radiation therapy as well, and we often consult our interventional radiology colleagues about radiofrequency ablation for isolated lesions as well. Just to note that liver metastases in colorectal cancer, survival is directly related to liver metastases resectability. We can improve overall survival greatly if patients have isolated lesions, and and our surgeons can successfully resect them. You know, way back when we would look at a CT scan and go, oh, there's 1 or 2 lesions, send them to surgery. But really now the techniques and technology have been so much more advanced. We're not limited by the number of metastases. That really doesn't factor in. We look at images, we discuss negative surgical margins, how much of the liver is still functional, how much would they be left with after a resection, and we're really looking at near zero operative mortality rate and long-term survival. And so we really discuss a lot of our patients at tumor board because it really has to be a joint discussion. And just because you have metastatic disease does not mean that we can't improve your survival with surgery. So now I want to sort of shift gears and talk a little bit about the main pathways that we're targeting in colorectal cancer, just to give you a flavor to understand that it's not just chemotherapy that we're offering. So this VEGF pathway, or vascular endothelial growth factor pathway, we don't really have a biomarker for it. We do know that these VEGF receptors are highly expressed in colorectal cancer, and they are drivers for angiogenesis, proliferation, metastases of colon cancers. And we have monoclonal antibodies that are directed targeting different pathways. So bevacizumab targets one of the ligands, VEGF-A, and ramucirumab actually targets VEGF receptor 2, and we also have aflibercept, which targets different ligands. So these are all biologic agents that we use and add on to our chemotherapy to improve responses. Fortunately, there's no biomarker. It's just something that we would offer our patients unless there were contraindications. And important for you guys to know is that there can be side effects associated with biologic agents different from chemo. In this case, with these agents, we would look at hypertension. There can be albumin in the urine. And they can cause bowel perforation and poor wound healing. So if we're anticipating going to surgery, someone just had surgery, we would actually hold off on giving these drugs. The other thing is there can be increased incidences of arterial thromboembolism and venous thromboembolism. And so we can sometimes, if they're asymptomatic, still treat them through that with anticoagulants, but these are also risk factors and side effects that we have to be wary of when patients are on these therapies. The other pathway that we are that heavily drives colorectal cancer is this pathway called the MAP kinase pathway. And on top, you can see that EGFR, or epithelial growth factor receptor, sits on the top. It's a transmembrane protein, and downstream of it are various proteins. And I've circled RAS because that is actually shown to play a very important role in the treatment of colorectal cancer. We have antibodies targeting EGFR, cetuximab, panitumumab up there. But we've also recognized that when RAS is mutated, it doesn't matter if we have the antibody to EGFR because it's mutated and is constitutively activated. It's like someone driving with the gas pedal down. So that's RAS pathway is activated downstream, so it doesn't matter that we're trying to hit the EGFR pathway from above. And so this was shown clinically. So there was a large clinical study looking at panitumumab and best supportive care versus best supportive care in patients who were heavily treated with chemo. There was an improvement in response rate from 10 to 37% with the addition of this one antibody, but it really didn't seem to affect or prolong survival. So in the top graph, figure A, you can see the blue and the yellow line. The blue line is panitumumab, the antibody. The yellow line is best supportive care. They're really overlapping each other and really don't seem to show that there is much improvement with the antibody. But when they went back and looked at this RAS mutation, they now separated and only selected patients whose tumors did not have that RAS mutation. And now you can see the blue and the yellow line separating. So the blue line, in fact, so the blue line showing panitumumab shows that we can actually benefit patients who do not harbor that RAS mutation. So this is a predictive biomarker because we now know that this mutation means that this antibody will not be effective in this patient population. So back to that, so understanding these pathways have actually really taught us how to better select patients and what kind of therapies we can offer them. So downstream is RAF. Downstream of RAS is BRAF, and I don't know if you've heard of BRAF mutations that can occur in melanoma as well as colorectal cancer. So now we also have studies out there where we're targeting RAF mutations, and we're targeting RAF, MEK1, MEK inhibitors, as well as EGFR. So different points in the signaling pathway to try to better improve responses and improve survival for our patients. The other pathway that's sort of ongoing with more and more data on is the HER2 protein. HER2's probably been best heard of in breast cancer, where they have a high level of this protein expressed on breast cancer. And if you have that, we actually have an antibody called trastuzumab or Herceptin that can target that protein and can improve survival. So we've also found that HER2 is highly expressed in certain colorectal cancers, about 5 to 8% of colorectal cancer patients. So then we wanted to look and see if this would actually improve patient survival just by targeted therapy and not chemotherapy. And the Heracles trial really looked at patients, only selected for patients who had high HER2 expression with trastuzumab, which is an antibody to HER2, and lapatinib, which is also a HER2 targeting agent. And this is what we call a waterfall plot. So if you look at this horizontal, each bar represents a patient. If the bars are going upwards, that means the tumor's growing. If the bars are going downwards, that means they're shrinking in size. So you can see that people who've had multiple lines of chemotherapy, if we give them this target agent and we're selecting for the right target, we can actually cause their tumors to shrink in size. And this on the right is a spaghetti plot, and that basically follows the progress of each tumor. So these tumors are growing in size as they go above the line, but these tumors seem to continue to decrease as they're shrinking and going below the horizontal line. So these aspects of cancer, colon cancer therapy has actually been very exciting, and we have a trial for HER2 positive colorectal cancer patients here at Emory as well. This diagram is really to show that we are now thinking of colorectal cancer not as one entity anymore. Yes, we're selecting for different targets, but we think histopathologically they're also very, very different entities. So the Cancer Genome Atlas looked at over about 270 cancers, colorectal cancers, and sequenced them and found different characteristics and lumped them into tumors who are hypermutated. So those are tumors that have that microsatellite instability, making all those mutation mistakes. There are tumors that are ultramutated who have mutations in polymerase E and polymerase D, and also the chromosomal instability patients. The consensus molecular subtype was sort of brought together by an international consortium, also acknowledging that we have different subtypes of colorectal cancer, and so they've been divided into 5 different groups. Right now, we are not utilizing this in a clinical practice, but I think very soon clinical trials will be subdividing and stratifying based on these molecular subtypes. I wanted to now move on to immunotherapy, which I find very exciting. So you remember I talked about Lynch syndrome. We were talking about mismatch repair and deficient mismatch repair tumors who are missing that protein or macrosatellite unstable. So there was a phase 1 study looking at what we call checkpoint inhibitors or PD-1 inhibitors. So basically PD-1 and PD-L1 and CTLA-4 are a class of ligands and proteins that we're looking at. And we think that in our body, what they they negatively regulate our immune system, meaning and then tumors have high expressions of these different ligands. And we think that it's a strategy that tumors have to evade our host immune system. Why is it that a tumor is growing in our body and our tumor doesn't recognize that as foreign, and we don't have this inflammatory system? And we think it's because of expression of these PD-1, PD-L1 ligands are sort of suppressing our immune system. So when we introduce these immunotherapy drugs, PD-1 inhibitors, PD-L1 inhibitors, we're basically taking the brakes off and letting our body mount an immune response against tumors. Now, this is an extremely simplistic way of describing it, but that's sort of how I describe it to my patients and sort of how I try to understand it. So when they did a phase 1 study with a PD-1 inhibitor, they found that patients who had mismatch repair deficient tumors were very sensitive to immunotherapy. And we're trying to understand a little bit more why that is. So when they look at mismatch repair deficient tumors, they have a large mutation burden because they're making so many mistakes, and we think that there are new neoantigens created. When they look at mutagen-associated tumors, we think of lung cancer patients because they're smoking exposure. We think of melanoma patients because they've had sun exposure. They seem to have a large mutation burden as well. But the majority of tumors that are mismatch repair proficient do not have that high tumor burden. And so we think that because of this high tumor burden, these tumors may be extra sensitive, and because of these neoantigens, may be more sensitive to these checkpoint inhibitors. So this was a phase 2 study done, pembrolizumab as a PD-1 inhibitor. So they selected for mismatch repair deficient colorectal cancer, mismatch proficient colorectal cancer, and also mismatch repair deficient non-colorectal cancers. If you look at the response rates, and these are patients who have been through multiple lines of therapy, the response rates were only seen in patients who had mismatch repair deficient tumors, whether it was colorectal or not. And then the disease control rate, which is basically the addition of response rate and those who had stable disease, was up to 92% and 70% in mismatch repair deficient. If we look at the waterfall plot, tumors that continued to grow on therapy and people who did not benefit from pembrolizumab were the mismatch repair proficient. And the people who had tumor shrinkage were the tumors that had mismatch repair deficient tumors. So based on this study, pembrolizumab was actually now approved for any type of cancer that might have that quality of deficient mismatch repair. And it's really been known as the first tumor agnostic therapy if we can find this quality. The unfortunate thing about this is that, at least in colorectal cancer, if we look at all stages, about 15% of the patients have deficient mismatch repair, but in metastatic setting, only 5% have mismatch repair. So we're always anxious to definitely detect the patients who have that mismatch repair deficiency, but now a lot of research efforts are going into the mismatch proficient colorectal cancers and how can we make those tumors sensitive to immunotherapy as well. So a lot of phase 1 trials are ongoing, and even phase 2 trials right now are to see how we can improve the immune response to fight off cancer. And those tumor responses did translate into improvement in survival. So the green line are patients with mismatch repair deficient tumors, and they're doing far better than the patients with mismatch repair proficient tumors. And this is for all cancer cohorts, and this is for colorectal cancer cohorts. We are now also looking and thinking of cancer differently, not only based on subtypes, molecular characteristics, but interestingly enough, in right versus left colon cancer, which was kind of surprising and kind of not. We knew that embryonically they started differently, the right-sided from the midgut and the left side from the hindgut. And we think about the different types of pathways that we are aware of for patients to develop colorectal cancer. We have the familial pathways that are Lynch and FAP that I'd kind of gone through. There are serrated pathways in the right side, and these are really people who have that BRAF mutation, who have MLH1 loss, which can give you deficient mismatch repair, and they're characteristically different than tumors on the left side, which have APC mutations and P53 mutations that accumulate and develop and become cancer. And so we are noticing that right-sided tumors occur in older patients. There's a higher incidence of female patients. There's a higher incidence of macrosatellite unstable or deficient mismatch repair proteins, and there are a lot more mutations, and generally worse prognosis unless they have that microsatellite instability characteristic. On the left side, we're seeing younger patients, predominantly KRAS, NRAS, BRAF wild type. They have that HER2 gain and seem to have a better prognosis. Now, what does this mean? Because one of my mentors told me, he said as soon as this news came out, a lot of his patients were calling and asking whether they had right or left side tumors. What does this mean? So it does change our practice. It won't change a majority of things, but it has been actually changing our practice. So the question of does side really matter in metastatic disease? These are large studies of thousands of patients where they're on a clinical trial, and they actually subdivided them into left and right tumors to see if their outcomes were any different. And if you look down the line, so in this study of over 1,000 patients, people were given different 5-FU chemotherapy combinations, but looking at survival, right-sided patients have worse survival than the left-sided patients. And in this study of about 400 patients, they looked at KRAS wild type, and they gave patients the anti-EGFR antibody or not. And again, only the left-sided people seemed to benefit from the antibody. Everyone else did not seem to have a change in their survival. And again, here shows that left-sided people do better. In this very large study, they looked at people with giving different types of chemotherapy with either bevacizumab that targeted the VEGF pathway or cetuximab, which targeted the anti-EGFR pathway. And there really was no difference. But when they looked at sidedness, they could see that the left-sided people, and this is a graph showing event-free survival, they could see that the left-sided, or the yellow line, people did much better than the right-sided. And then if we split that population of left and right up to the type of therapy they had, we could see that left-sided people who got cetuximab, which is the pink line, did much better than the left-sided people who got bevacizumab. And in fact, the green line showing the right-sided people who got bevacizumab did better than the right-sided people who got cetuximab. And this data does actually change what we do. Another large trial, this side, on the left side are all left-sided tumors, and on the right are all the right-sided tumors. And this was chemo versus chemo plus an antibody. And you can see the orange line, which is the chemo and antibody. People seem to benefit from the addition of the antibody to chemotherapy if you had left-sided tumors. But if you had right-sided tumors, it didn't really matter whether you had chemo with or without the antibody. So this actually has changed our practice. And now we really think of where the tumor started from. Was it right-sided or left-sided? We're looking at different molecular characteristics. We're thinking of how we can target these characteristics. And it really has changed our practice because this is the NCCN guidelines, which is the National Comprehensive Cancer Network, and it has a consortium of experts coming together to decide on, to give recommendations on how we treat colorectal cancer. And right here in small print, it says we can give FOLFOX, which is a chemotherapy with the anti-EGFR agents, if they're NRAS, KRAS wild type, and left-sided. So now this has made a big impact on how we decide on how to treat our patients. So right now, as a patient comes in clinic and we think about how we're treating them, stage, what molecular features do their tumors show us, where is the location, is it right, left, or rectum, and also patient comorbidities, and how can we help treat our patients. So going back back to the very beginning where we talked about the case study. So we have a 55-year-old patient who's been actively dieting and exercising, presenting with rectal bleeding, constipation, weight loss. So first of all, he should have had a colonoscopy. He's 55. So screening starts at 50, so he should have had a colonoscopy. The other point I wanted to make was that his father had colon cancer at age 50. So when you have a first-degree relative who had a colon cancer, we actually should start our screening colonoscopies 10 years junior to that. So in fact, he should have started at age 40. And the final point is that anybody who has microcytic anemia, think about doing a workup to make sure we know why they're losing their blood. And so in summary of the talk, we know that colorectal cancer incidence and mortality is improving, but there's an opposite pattern in younger patients, and we have to work them up if they have presenting symptoms, and we have to do better. Screening and treatment for colorectal cancer has significantly improved outcome. Be aware of familial syndromes and know that if we diagnose them, that they have their own screening guidelines that we have to then follow. And management of patients with colorectal cancer is really guided by stage, location of the tumor, patient factors, and molecular profile. Okay, that's it. Thank you.
Very good. One question I would ask to start off is, as you look at the changing tumors and you look at the various percentages of the frequency of occurrence of that, are you seeing a change there, like there's more Lynch syndrome in the young and it is increasing or not?
So that I think we're better at detecting it, so I think there might be some bias on that end. But to be honest, we've also had elderly patients 70 years plus that because we're screening them, we have identified Lynch as well. And we're detecting that more and more. So I think right now, as we're starting to screen, that might be a little bit more skewed. We might have a little bit more information about that at a later date of whether younger patients are having more Lynch. But there are a lot of patients who do not have a hereditary component to it, unfortunately.
Okay. Other questions?
So a couple of questions. I wanted to follow up on Doug's question about I still don't quite understand the increasing incidence in the young. And can you comment on that? Are those mostly left-sided? They sound sporadic from your answer just a second ago. And do we know any more about the molecular pathogenesis of these increasing number of cancers in the young? That's one question. Second question has to do with salicylates and the well-observed effect of salicylates. And do you have a mechanism around why salicylates are protective against colon cancer?
So first of all, with regards to the younger patients and if there's certain molecular profiles that we're noticing, there actually have been a few abstracts and publications looking at that. At this moment, we don't know. We still can't pinpoint like a certain pathway that might be driving this in younger versus older patients. I think as we look at the molecular subtypes that I mentioned, I feel like we are going to be able to put that together more. But as of this moment, we still don't really understand why there is an increasing incidence in the younger population. So secondly, about the aspirin, there have been large observation studies where they sort of followed the Women's Health Initiative in Boston, where they followed people, nurses, doctors, and they sort of picked up on people who eventually developed colorectal cancer or any type of cancer and sort of recorded their patterns. And that's where I think aspirin and a lot of these other protective factors came up. We do know that the COX-2 inhibition can be helpful. There were a large study looking at COX-2 inhibitors at one point. We had a large phase 3 study for stage 3 colon cancer patients where after they got their chemo, we actually randomized them to COX-2 inhibitors versus not. We don't know the data for that yet. There's a lot of observational data that are supporting that. And that CAP2 study for Lynch syndrome patients specifically does suggest that direction. But so that's sort of where our data is. We don't have biomarkers as of right now to say that, we think that PIK3CA, which is another mutation that may occur, may mean that people are going to have more protective effect from aspirin. But we just don't know that as a hard recommendation at this point in time yet. But yes, there is a suggestion of a baby aspirin or something being protective.
Actually, some of the recent data suggests that aspirin is probably more protective from colon cancer than it is from coronary disease.
Mm-hmm. Yep.
Yeah.
That was really great. Predictably, I have a question about the elderly patients in the study, and you had suggested that the incidence in older patients was down with regards to colorectal cancer. That's fascinating that older folks would have a declining interest. Does that speak at all to what's going on with people who are now in their 70s who had colorectal cancer screening via colonoscopy? Is there more importance or value of the colonoscopy for screening at 50 than there is for the third colon screening at 70, for example?
Yeah, so you're asking when do we stop screening or no?
Sorry. So incidence in colorectal cancer going down with aging is just surprising, first of all. And then the second part of the question was, is there more value for the first colorectal cancer screening at age 50 than there is with the third colorectal cancer screening at age 70?
I think potentially yes, because we know that colorectal cancer usually is diagnosed in people age 60 to 70. That's been the norm before until we now see this emerging pattern of younger patients. So I think that population of 60s to 70s we're doing better with because of that colonoscopy that's done earlier in the age, around the age of 50. We're catching the polyps so they don't become colon cancer. So yes to the answer that question. Yeah.
So very nice talk. You briefly mentioned about diet being, a contributing factor. So in the younger population, is it maybe more of high-fat diet? And along those lines, can you talk a little bit about gut microbiota changing? So that's one question. And then I have a second question. You talked about the HER2, and on that same slide you had some neuregulin, I think, those receptors. So the nervous system of the GI tract and the neurotrophic factors, has that been looked at in relationship to colon cancer? So two very different questions.
So these are really hot topics right now. We do think diet probably has a component to the younger age of incidence of colorectal cancer. The microbiome is extremely exciting right now, especially also looking at microbiome and how it may affect our immune system. So not only in the development of colorectal cancer, but also in determining whether we can make people more sensitive to immunotherapy. So that is a really hot topic right now. As to what is the best mix of microbiome in our bowels, we don't know yet, but yes, I agree. And the question about nerves and such, yes, that's definitely very significant. I think more to come for that. Yeah.
We have one question from Grady. They were kind of piggybacking on that last question. Is there thought to be contribution from a difference in the microbiome that's in the difference between right and left-sided colon tumors? Or?
I think that very well could be. I don't know that we know enough, but yes, I think that's a great question and a great point.
Any other questions? Boy, thank you.
Thank you.
Superb talk.